Welcome, and thank you for joining us for part 3 of the Converting Big Data into Actionable Results series, titled Using Answers for Action. During this last session, we will focus on how to use descriptive, predictive, and prescriptive analytics to craft an effective strategy and impact the bottom line. Our presenter today will be Todd Sutherland. Todd is a trailblazer in the field of healthcare technology and data analysis. Now he is working with YourCareUniverse to bring the first cloud-based, real-time patient analytics solution to life. In order to keep background noise to a minimum, everyone will be muted throughout the webinar. We encourage your questions at any time throughout the demonstration. Just type your question in the chat box and we will answer any questions at the end of the session. Todd will take it from here.
Thank you, Lauren. We appreciate everybody being with us today in this part 3 of a 3-part webinar. And today we're going to focus in on how to take action from all of the data and analytics that we've covered today. Before we get into taking action, I wanted to take a quick second to review what we've learned along the way. In the very first webinar series, we talked about creating a solid foundation around data and tools. And in particular, we looked at the different types of data that you may encounter, from structured, semi-structured, and unstructured. And we talked about tools to handle this data, whether you are trying to visualize the data, organize it into a database structure, and or run statistics on the data. And in particular, we discussed descriptive statistics. As we mentioned in that very first series, one of the big promises of all of this data that we have flowing through our organization today is really the ability to ask the right question. And I found a very good quote from Claude Levi-Strauss that mentions the wise man doesn't give the right answers, but poses the right question. In part 2, we shifted our focus to knowledge and gaining knowledge. Here, we also asked the most important question around data and analytics is why? Why are we doing this? What's the purpose? What's the outcome? We talked about an analytics planning framework from descriptive analytics to predictive analytics to prescriptive analytics. We're going to, in particular, dive deeper into the prescriptive aspects today. And then we also looked at more tools around this particular area of analytics. The promise of analytics is really a crystal ball, to be able to look into the future and know what is going to happen tomorrow, next week, next month, next year. So knowledge is really the continuous pursuit of learning. And whenever you overlay analytics into learning, there is a circular relationship that occurs. And there are really 2 elements. One is competence and one is confidence. And as you gain more confidence, you typically will gain more competence as well. And so there is a circular relationship between all of this learning and analytics that we're doing. In part 3 today, we're going to use these answers for action. And in particular, we're going to show you how we are doing this today at YourCareUniverse and the processes that we go through. So in that review, from a strategic planning perspective, the data really aligns itself to the assessment part of the strategic planning framework. The analytics apply itself to the decision point, and I think in terms of an hourglass, so at the top of the hourglass, we're taking in lots of input and data and information, but we get down into that decision point that we have to make a decision, and then we can flare it back out at the bottom with the action and execution. The first most important step always is to list the opportunities in front of you and prioritize those opportunities. I like to prioritize using a return on investment model that I've built over the years, and this helps me determine what the revenue impact would be for every dollar I spend. So I want to maximize my return. Then it's very important to execute on the number 1 priority that you select. Last but not least, once you begin to execute, you want to make sure that you have built into your process the ability to test, analyze, and repeat. That is very important because analytics are dynamic. They are constantly moving and always changing. So if you don't have this phase built into your process, what you'll wind up with is getting to a point in time making a decision and then lose some of the critical aspects of prescriptive analytics. To just bring the audience back to the planning model, this is the Veros planning model that I built a couple of years ago. And what we've done here is taken a bit of a traditional approach to strategic planning, but we have flipped the DIKW pyramid upside down: data, information, knowledge, wisdom. Typically, you would see wisdom at the top of the pyramid, then knowledge, then information and data supporting it. I think it's exactly the opposite. As you think through implementing your strategy and taking action on a particular problem, the first thing you need to do is gather data, understand your strengths, weaknesses, threats, and opportunities, and run that up against your core values, mission, vision, and identity. The next thing that you want to do is look at that information from a perspective of assessment. So what are the strategies available to me? What are my risks? Are there any insights that the analytics can provide to me that I would have otherwise missed? And then where are the market opportunities that exist in the market that I'm serving? And then are there metrics and benchmarks and other BI tools that can lend information into the process? So I probably deviate a little bit from some of my other fellow data scientists in the world in that I really differentiate analytics from BI. Business intelligence typically has been focused on the return of data and information from inside the organization, as opposed to aggregating both internal and external data to come up with an answer. It has been more of a reporting element than anything else. I do think these systems will evolve over time and probably move more into analytics. Third would be knowledge. This is where we look at setting our goals once we have that information. And then for the goals that are evolutionary in nature, those are really going to be continuous quality improvement, CQI. This might be to continue to reduce readmissions in the facility, lower our hospital-acquired conditions, hospital-acquired infections, improve on our net patient revenue numbers. Those would be smaller, more incremental changes that we'd be trying to make on a given basis. The other side of the triangle is venture innovation. And this is really where we have more of a revolutionary strategy where we want to try something new. We'll talk a little bit more about this later in the session as well. And then last but not least, once we have the data, information, knowledge, made our decisions, started setting our goals, we can now get into the wisdom phase, which is really about execution, making the right decisions, the right time, every time. So what are those strategies? How do we allocate resources to those strategies? Which ones are driven by objective versus policy? Very big differentiation there. Last but not least, on the bottom, the ability to create dashboards now to track and measure the improvement of these strategies, to evaluate them, and to gain feedback over time. So as we get into actions, one of the things that we see today is this problem that exists in the marketplace where many organizations have created a silo effect within their analytical framework and infrastructure. What I mean by that is that there are many organizations that are buying a single CRM tool that's not informing their PRM. Consumers and physicians in healthcare are still tightly integrated and will be for the foreseeable future. At the same time, we have additional outside data from a community analytics or market analytics that's not being integrated with either one of those. And typically our financial analytics are not informing either one as well, not to mention the clinical analytics side. So we believe that there's a better way to go about doing this, whereby a community can truly build upon a true EMPI, Enterprise Master Patient Index, to capture and collect data across the entire community, no matter what the point of care is. Now, the data aggregation warehouse is outlined there as some organizations are attempting to solve this problem by creating these massive data warehouses to feed all of these different data sets in. The problem is still that most of the data sets are up a level higher where people are interacting with the CRM and PRM, and they're not getting that knowledge back into the warehouse. So we think this is a pretty significant problem as we begin to move into potential care navigation strategies and look across the whole continuum of care, from wellness to pre-acute to acute care to post-acute back to a well state. If you remember from our last session, we introduced a new term, and I'm growing to love this term more and more. I've been able to use it several times in the last 2 weeks. And it's really, I think, the next phase beyond analytics, where it gets us beyond our current thinking today. So in the ability to have knowledge is really power. First and foremost is data awareness. What do I have available to me in the market today? Believe it or not, there are a lot of organizations around the country where we spend a lot of time educating people just on what data is available about their physicians, their consumers, their payers, all of the stakeholders that they have in their marketplace. So having that data awareness is really important. The second component, as we mentioned earlier, is business intelligence. So what is it that I have currently coming out of my systems that would help inform where there are opportunities for me to improve? And then third would be data enhancement, the actual ability to take every single record that you're producing from the enterprise and add additional value into those data records by appending information onto the records, whether it be environmental, demographic, psychographic profiling. Lots of different variables can be added into the information. So that process is really turning knowledge into wisdom so that you can have a more informed executive committee, management team looking at this. And I would also challenge the thinking that if we make this information simple enough, it can actually be pushed down deeper into the organization so that the decisions are made at the point of patient care. And that's really the state of omnics that we want to get to. And that is a state of knowing all. So every physician in the world would tell you that the state of nirvana with patient care is knowing every single thing about that patient at the point they're sitting in front of you, so that you can make the most accurate diagnosis for that particular patient. So we're not quite there, but I think this is a wonderful sort of future vision for us to get to. The next thing I wanted to focus a little bit on, and this comes back to the previous slide of being data aware. So I do a lot of what I call mind mapping to take a process and go through the entire process and think about the points of opportunity that exist in the healthcare system today. And I typically will look at content, commerce, and connectivity. And so as we start with the consumer who as well begins to watch television or gets on their iPad today and starts to ask questions. It's quite entertaining that this graphic was designed in 1998 with a friend of mine who's a graphic designer who took all of this off of a whiteboard and did just a fabulous job, and it's still very pertinent today. So a physician is consulted. They're going to run some tests. At this point, right, we have the opportunity to begin to provide the consumer with content about their specific disease and do this in a way that builds on top of the patient's electronic health record, electronic medical record, so that it can be captured over time. Second would be the commerce opportunities that are present. Obviously, we're going to be running lab tests. There would be transactions that happen between your organization and the consumer. And then connectivity for us would be the ability to capture that information and enhance the data, provide that information back to the consumer and back to the provider. So all throughout this process, there are multiple touch points for opportunities for both the provider and the consumer to really get more engaged with the process. From an omni data state, these are some of the data sources and appending that I use whenever I look at analytics, and certainly we are leveraging these today in the YourCareUniverse. So demographic and psychographic profiles, we get that information from ESRI. Community Health Service Demand, this is the National Hospital Discharge Survey, the National Ambulatory Medical Care Survey, the National Hospital Ambulatory Medical Care Survey, and the National Health Interview Survey. These are longitudinal studies that have been done for more than 30 years, and they provide us with an excellent view as to the normal state of healthcare given an age, gender, and race stratification. So this provides us with the baseline for the community. Next level up is environmental from the EPA and NOAA. We're taking air temperature, air, water quality data in from well over 1,000 zip codes on an hourly basis today. That information can be appended into the clinical record, and we can start to see what the environmental effects are for healthcare. The next area would be CMS clinical data. This can be used either for modeling purposes, so that you can have a much broader sample to begin to understand, for instance, bundle payments around knee joint replacements for DRGs 469 and 470. We can begin to look very deep into the profiles of the beneficiary and begin to understand what the pathway to care looks like and be able to benchmark and compare that on a national basis, state by state, and down to the market level. There is additional data from CMS and other all-payer state claims data sets that can be appended and overlaid with the information as well. This can give us market share, start to look at referral patterns and trends. Then we can also start to look at the client clinical data, so bringing in the CCDA, which is the Comprehensive Clinical Document Architecture, in particular the CCD, the Continuing Care Document. This is a document that has data all about the patient, the care team that's providing that care, diagnosis information, procedural information, lab tests, imaging tests that come back, and then also it contains family and social history. So it is truly revolutionary what's going on in the healthcare space today. And if you're not looking at this data as a source within your organization, you're missing a big opportunity. Next area, all the HL7 messages, ADT, SIU, ORU, ORM. We use this really in our time series to track and measure additional elements about that patient that are not captured in the CCD. Additional financial data that we can overlay from 837s, 835s, and also take a look at the inpatient prospective payment system and the outpatient prospective payment system, and HCRIS, which is the hospital cost reporting information. All of that now gives us a very clear picture of the patient from both a clinical perspective, a financial perspective, and an administrative perspective. Hopefully that makes sense. The next state is how we are viewing analytics today, and we think that from a perspective of knowing all, that you have to start with a global view of the data and information. The other advantage of looking at it from a global view, certainly from our perspective, we're looking across the country at multiple hundreds of facilities. We have very deep cells that we can fill up and begin to understand if left-handed females with COPD come to the hospital every Thursday. That might be a very important finding, and that's the level of detail that we weren't able to get to even just a few years ago. So This whole study of healthcare analytics is still fairly new, and I would encourage you, if you're interested, to begin to start to learn about the different data science toolkits that are out there, and be glad to share more information about that with you at the end of the broadcast. I will take a quick stop here and remind everyone to send us in any questions that you have through the chat function, and we'll be answering those questions at the end of the broadcast today. The next level we look at is really a corporate view. It may not pertain to all of you. Some of you may be single entity hospitals versus corporations. In this particular case, we will break down the corporate into divisions and markets. We also have a different level, which is the community itself, which we typically will define as a CBSA. And then any contractual organizations that fall into a clinical bucket, which we call clinical care organizations. These would be your ACOs, clinically integrated networks, physician hospital organizations, anywhere you have a group of people that are coming contractually together to provide care. Last but not least is that facility view. So this can be a hospital, it could be a clinic, it could be a multi-specialty group, or it could be an individual physician. Physician practice management systems also have the ability to provide that CPDA, ADT, 837, 835 claims data into an overall system record. Last but not least is the household view. For those of you that provide care or clinical on the call today will be quite familiar with the concept. But unless you understand what environment that patient is getting discharged to, you put yourself at a very high risk in a provider state today. So we really want to be cognizant of whether or not there is a family network at home to provide care for this patient after they get discharged from our facility. The last level is obviously the patient or the consumer view itself. So these would be the different components that we need to be focused on this particular patient. So in terms of creating effective strategies, as we start to move into more of the actions, the first thing that we always want to do is to make sure that we have aligned our department goals to our corporate goals. This is a step that I see skipped pretty frequently as I meet with hospitals across the country. And why this is important is if your departmental goals are not aligned to those corporate goals, over time you will start to deviate from the direction that the overall company is headed in. And that can be very deadly for job security and other components like that. Plus, what we find is typically there's a waste of resources that should have been focused in other areas. So always make sure that on at least an annual basis, if not even more frequently, that you're doing that alignment process to see where there are gaps from the corporate strategy into your departmental strategies. Next, you want to determine whether or not these strategies are evolutionary or revolutionary. We talked about that earlier on the planning model. So I would also propose that if they are revolutionary, that you might even want to consider a small off-site SWAT team type of approach. I've seen this work very effectively here in Nashville, Tennessee, where we have a wonderful entrepreneur center which allows for corporations to actually come in for 30, 60, 90 days and work on the launch of a new product. It's a very different type of approach than most hospital organizations have done in the past, but one that is very effective. Same type of strategy FedEx uses over in Memphis as well. So I think if we start to look at how to get innovation to take off in healthcare, this will be one of those very important elements that needs to be considered. If it's an evolutionary strategy, I'm a big fan of assigning strategies to individual C-suite members for them to execute and track and report back to the whole team on. It gets everybody involved, and it makes sure that no one strategy is left without an assignment. And then I like to track and measure these strategies on a monthly basis. I boil everything down into a monthly tracking presentation that can quickly be updated. And where possible, I like to put those elements into a dashboard where everybody can see them. It makes a great addition onto the hallways of the management team. Most of you are probably familiar with this acronym, but I'll just bring you back to it very quickly. SMART goals. We're coming up on the end of the year, and we'll all be setting lots of goals for ourselves and our organization. I think this is one of the best ways to go about through the goal setting process. So we want to make sure any goal that we set, whether it's analytics or outside of analytics, that it be very specific, measurable, attainable, relevant, and timely. Once again, if you are aligned with your goals and strategies to the organization, then relevancy always takes care of itself. Last but not least, whenever you have a goal that doesn't really fit into this box, I would propose that Mr. Collins was correct in that is going to be a big, hairy, audacious goal and something that you might want to focus the entire organization on if it's truly going to change how you've been thinking and doing business. And there are a lot of those for healthcare today. Next, it's very important as you start to take action to know your buyers. And yes, these buyers are both internal and external. From an internal perspective, CEOs across the country today are telling me they're most focused on revenue, implementation of strategy, building market share, and creating success for the organization. So as you think about analytics, you want to think about how the story that you're trying to build with analytics can help address these value propositions for each of the buyers. Our CFOs of the world are very focused on cost, decreasing those costs, driving efficiencies within the organization. COO, this is one of my favorite acronyms that I ever learned, and this is efficient, effective behavior by rational individuals. COOs love it when we can actually get the environment to be like this. Unfortunately, we have a lot of drama in our world, and this is rarely the case, but any analytic process that can drive this type of behavior will be well received by the COOs of the world from an operations standpoint. Next group are the chief medical officers and chief nursing officers. They are responsible for driving this quality excellence initiative throughout healthcare, and that is where they're focused and should be focused, especially from a patient care perspective. The CMO, the chief marketing officer, is responsible for growth and brand. And once again, analytics is so very valuable in this particular area to look for growth opportunities, but also how they're going to impact the brand value from a long-term perspective. The next area that we're going to look at is external customers. And so these are your additional stakeholders that you need to be aware of. Patients. I believe still today that patients are looking for value. They are looking for the highest quality experience at the lowest price possible. Now, there are still a lot of individuals, and I would call these non-rational individuals, that are looking for the highest quality experience no matter what the cost is. I do think that that is going to change at some point in our lifetime. I don't know when that period is that we're going to cross that chasm, but I can certainly feel that it's coming, and we see incremental survey data already coming out that it's beginning to change. So be aware that this is happening, because this is going to be a monumental shift in how consumers interact with healthcare over the long haul. Next is the community. When we do community health needs assessments throughout the country, the number one priority is to help us improve the status of our community. So looking across, are we higher in diabetes than we ought to be? Are there opportunities for us to improve the quality of water? Different areas like that that we want to be focused on. Last but not least is government compliance. We want to make sure that we are abiding by the laws and doing everything we can to both protect our patients, our employees, and everyone who is involved in delivering care. As I mentioned earlier, one of the things that I do whenever I'm setting up for an action state is to get consensus on what the return on investment model should look like, what elements should be included in that, and what do we expect the return of that data to yield to us. So in this particular case, I took a sample from a recent engagement that we did with a client, and we began to figure out where we could impact both hard dollars, meaning real revenue that was generated out of the new processes that were put into place, versus the soft dollars around value add, whether it's community perceptions, a more informed patient, more efficiency in the healthcare system. And I believe there's another category I'm going to add to this that I'll throw out today, and that's really around economic benefit. Many communities that we're working with across the country are experiencing anywhere from $25 to $100 million of clinical care leakage from their community to larger tertiary centers. Some of that is actually justified because the organization doesn't provide the level of clinical care that the community needs. So high-end neuro, trauma, cardiac, some of those procedures. However, most hospital organizations should have as a goal to capture 100% of what they can do clinically in the local community. It benefits the hospital, it benefits the foundations of the hospital, it benefits the local physicians, and if you think about driving $25 or $15 million annually back into your community, think about the economic engine that is created when that situation occurs, and why the whole community should be focused on that as a goal as opposed to just the hospital. We think that's a pretty big change of thinking for a lot of organizations across the country. As I mentioned up early on about knowledge, it is extremely important to think about implementing these learning systems. And to do that, you have to begin to break down the process of analytics and think about the timing. Is this something I need to look at and check in on every single day, once a week, once a month, once a quarter, once a year? What is that timing that I need to look at it? And then more importantly, what is the timing when I need to adjust my models? Are there triggers that we've set up that when we get to a certain level of confidence or fall out of a certain level of confidence range that we need to adjust the model? We also need to understand what the data intervals are. When will the data be updated, whether that's internal or external data, and clearly map those out throughout the process of a year. We are big proponents as we move YourCareUniverse into this real-time patient analytic model, which we're at today. The ability to have what I call inline learning, so to actually see that flow of data come in and be able to interact with it real-time is a whole new experience for many of us in the data science world, and that's really where we are today. So we have to be able to look at the history, be able to see what's happening real-time today, and then predict into the future. Last but not least is understanding the response mechanism. So as we take action and we begin to insert ourselves into the data model itself that's going on in our community, every response mechanism is going to change the model and the impact of the model. And so first of all, you have to plan for that situation to be there. And then second, it's important for you to know how you're going to adjust if the positive, which is what we planned for, occurs, or the negative, which we didn't plan for, occurs. And believe me, in the world of analytics, there are a lot of unintended consequences that occur every day. The next stage of this is really about becoming prescriptive. This is the area of analytics that you're going to hear the most about over the coming 2 to 3 years. And this is where we insert our influence into the model. So our care networks have already been established in our communities. They work fairly efficiently today. And then what we're going to do is start to understand how those care models are working and where we can actually drop in and begin to influence those models. In particular, what we like to do is to develop that hypothesis of what we're studying to see if, in fact, we have sufficient data that would point us to understanding this hypothesis so we could say, yes, this hypothesis is true or this hypothesis is false. I will tell you it's just as important to find the false as it is to find the truth in the data. Next, you want to test the hypothesis. I'm a big fan of A/B testing. I think this yields great experience and learning as we begin to put different elements both in front of internal and external users. All too often, people only use A/B testing with consumers and rarely forget about the internal employees that they are working with. Next area is to execute on that hypothesis, put the data model into place, start tracking and measuring that over time, analyze those hypotheses on a daily basis, weekly basis, monthly basis, whatever your data timing looks like, and then do, as I say, lather, rinse, repeat. So we want to shake things up, we want to clean it all out again, and then we want to repeat that process over and over and over again. And that's what makes analytics so fun. The next area is machine language learning. This is another area that we are beginning to investigate and play with. We think it holds tremendous value and potential just because of the sheer magnitude of the data and information that we are dealing with across these hundreds of clinical care organizations. So in this particular case, instead of forming our own hypothesis, we can actually let the machines begin to formulate and understand where there are clusters of different actions that are going on, whether they be demographic, family history, social history, past diagnosis, wellness data, current diagnosis. Are there elements of data that we should be focused on that we've totally missed? And it's pretty easy to say as we age in healthcare, we're going to increase our need for healthcare services. So age is always a very high determinant on a lot of different diseases. Now, as you look at age and you start to look at an element like cervical cancer, the age parameters actually change on that particular disease state. So you do want to begin to look at different disease states by different factors. Now, there are probably more disease states than what an average person at a facility could even handle in a given year. So this is where machine language learning can come into play and really tease out new information about your community that you've never seen or been experienced with before. So what I want to do is begin to walk you through a case study here at the last part of today's session, so you can actually see what this looks like from our perspective in the marketplace. So as we go through this, this is a real live case study that we've done on hips and knees. We took a massive amount of data, more than 2 million records that we started with and combed through it. We looked at it from a disease graph perspective, and that's what we call a deep dive into one disease condition. We began to execute against the data and information that we found, looked at changes in some of our operations within the facility. We implemented a persistent CRM campaign in Salesforce. We tracked those responses. We quantified the ROI. And as we mentioned before, that gets us to this omni-omics view of the world. So the hip joint replacement profile, we pulled out about 2,034 unique patients that we identified with an algorithm. We extracted out their records and began to do a deep dive. We found that their average age was 70, median household income was $51,000, which was $2,000 below the national average. Very large percentage of these people were in household units. Diversity index was a little low. mostly white patients. 57% of the patients were female, 59% were married. More importantly, there were 2 life modes that accounted for the majority of the patients that were suffering hip replacement: cozy country living and Gen X urban. So that's a very important finding, and we'll talk more about that in a few slides. But in particular, salt of the earth and green acres have a very high likelihood of having a hip joint replacement. So this is a demographic profile. So what I'm going to do is I'm going to actually drop over, and I'm going to show you what this actually looks like in YourCareUniverse. So we're going to click on disease, and we can come down to our orthopedic area, and we can actually look at the hip index and look at the demographic profile on the screen. One of the things that we do within our analytics and our analysis is the data that we have is what I call persistent. And so what that means is I can come over here and I can click into females, and then I can also begin to look at married females and begin to see the differences in ethnicity and other elements that might play a role in my predictive analytics on whether or not this person is going to have a hip joint replacement. The second thing that I would do is begin to drill down into the hospital level. And so I'm going to pick Sunrise Medical Center out in Las Vegas. And what I would do is I would begin to start to look at the market map. So these are all of the shared clinical visits that are occurring in the marketplace with Sunrise. And we're going to go look for orthopedics. So orthopedics are down here. So these boxes are relative to the number of shared visits with this organization. And so we can see that Silverberg represents a large amount of the volume with this hospital, and then Bradford. And then we can go over here and look at Bradford's clinical profile. So we can actually see what types of procedures that Bradford is doing. These are HCPCS, CPT coding. And so we can see also what the level of new and existing patients are within this particular practice. So as you can see, it's actually a little higher than normal, but we're seeing about 20% of their practice is in fact new patients. From a coding perspective though, the coding is a little lower than what we would anticipate. So we're looking for normal distribution curve with 213 being in the middle of the chart. And so there's probably an opportunity here to do coding lift with this particular position. The next thing we'd want to do is then take a look at the specialty flow. And this is where we can begin to drill down into our primary care base and specifically look at orthopedic surgery. And so we can see where the flow of primary care to specialists is occurring for our hospital. And then we can also now quantify what the out-migration or leakage is occurring as well, and which physicians are driving that. So that gives us a whole new level of understanding about the market and the information that we didn't have before. And this is a lot of where we're talking about increasing our capabilities to understand. The next area that I want to show you very quickly is what we're doing in Salesforce to take this campaign into action. So what we're going to do is we're going to log in here as a YourCareUniverse user. And we have a campaign that's already in process and running. And so we'll go look at the dashboard first and begin to understand how our campaign is performing. So we'll scroll down. So we see where the hip replacements are today, how the campaign has been performing. And so this is very important because, remember, we want to test and repeat as often as possible so that we get smarter and smarter about what we're doing. So in this particular case, what we see here is that our telemarketing is actually driving the greatest response. So we may not want to turn off our email and text because those are more efficient ways to communicate with consumers, and we are getting results from those. We might want to change the message slightly But we also might want to double down on telemarketing, because we know when we call people, we actually get a response. So pretty big opportunity for hospitals to drive down into that action state today, like we've never had that opportunity before. The next area of the profile deals with psychographic profiling. If you're not familiar with that term, psychographics are akin to demographics. Demographics tell us age, gender, race, household income, educational attainment. Psychographics deal instead with how we spend our money. So what's the difference between a red wine drinker and a white wine drinker? People who go to Target versus Walmart. Do you have a home tiller? This is the type of level of detail that we can get down into, and we can append this data and information onto the patient record so that we can begin to differentiate hip replacement with knee replacement and see if there are differences in lifestyle, life modes that are impacting those disease states. So in this particular case, what we're seeing is a big concentration here in the 21s and the 22s and even down to the 24s. Each one of these profiles has a specific title and detail behind it that Esri provides. So what we see here is the salt of the earth is about 12% of our hip profile, and green acres are 9%. Once we identify that, we can begin to understand where potential leakage in our community can come from. As we look at those orthopedic physicians in Sunrise, where those shared visits are, one of the things that we came up with is our estimate of about 18 to 20% of these patient types are leaking out of the market, and that projected leakage translates into about $2.8 million that we could capture. It's certainly procedures that we're capable of doing, and then there's an additional coding lift for each one of those physicians. These are the life mode groups themselves: cozy country living, salt of the earth, so you can see not only where they live in the country, but a little more detail as to what is comprised in these particular households. And this is the green acres index as well. So we start to summarize then from a statistical methodology what these patients are like. The mean age is 70.6. The mean risk factor for hips, we found at 1.5, and we found a statistically significant relationship with age, as we talked about earlier in the process, but there is a weak negative relationship with the risk factor for hip incidence. And so we want to continue to drill down into that and find out what else is going on. There's also a strong spike in the risk factors between 39 and 43. So even though it might be 70 before you have the procedure, a lot of times there are accidents and other things. The weekend warriors have lifestyles at these ages that impact the future state of healthcare. So this will also indicate a much greater need for longitudinal data analysis across. And that's what this mean risk factor looks like when you break it out into a chart. These are the count of the patients, and you can see where the spikes occur here in age 70 as our top. But there are also spikes along the way, and so as we dig down into each of those, we can begin to understand what those look like. We also took a look at hospital-acquired conditions. So 12 of the 2,000 patients did experience a hospital-acquired condition. All 12 of the patients lived in a rural or semi-rural area, so that was kind of interesting. So access may have an impact into hospital-acquired conditions. 9 were members of Tapestry Life Mode 6, Cozy Country Living. 12 of the patients with HACs at one facility, 7 of those patients were female. So that is another piece of the puzzle that we're trying to begin to understand of how we avoid hospital-acquired conditions. 6 of the patients were white and 1 was black. 3 women were divorced, and this is the level of detail that we try to get down into when we're looking for these actionable opportunities around analytics. When we get down into the person level, we can actually see a high offender in terms of hospital-acquired conditions, and we can see specifically what those procedures were that this patient had that caused those problems at the facility. I quickly showed you Salesforce, so I won't go back to that, but know that you have to drive this process into that last action state as quickly as possible so that you can get a true return on investment on your dollars for analytics. Last but not least, we like to put everything into geospatial analysis as well and begin to understand, are there groupings of neighborhoods, and there are groupings where we see hip replacements being higher than other parts of the city. And so those attributes can then be connected to other elements, either occupations for those particular areas, parks nearby, other elements in the environment. So quick review, three-part webinar series. We've looked at data, analytics, and action today. And so we appreciate the opportunity that you've spent with us and look forward to helping you in the future. One thing that we'd like to do is end with a quick video to bring all of this together for you. And so I will start that up. And then in the meantime, if you have any questions, please submit those in the chat.
YourCareUniverse is improving the way healthcare providers engage and interact with the healthcare consumer. There's a world of change occurring throughout healthcare, increasing competition, changing reimbursement models, and sharing of risk across all parties. Most impactful is the consumerization of healthcare. To thrive in this new landscape, your sphere of influence and care needs to extend beyond the four walls of your care center. You need to understand and engage the consumer, placing them at the center of your organization's strategy. YourCareUniverse is an integrated consumer engagement solution, facilitating asynchronous interaction between providers and patients. The solution provides clear visibility into what's happening within your organization, across your community, and beyond. You need answers, but first you need to know what questions to ask. With actionable analytics, you can drive both the right questions and the right answers. The YourCareUniverse analytics tool helps you understand what the numbers are in your population sets with descriptive analytics, anticipate what the future will bring with predictive analytics, and influence consumer behavior using prescriptive analytics. YourCareUniverse Analytics connects the dots between consumers, patients, physicians, and other care providers, helping to optimize revenue and drive profitability, build brand loyalty through a better patient experience, and maximize service line efficiency. An integrated solution with embedded actionable analytics driving decision-making across the entire engagement platform. YourCareUniverse Analytics gives you the information you need to understand your environment, gain wisdom, and take action. Learn more. Contact us today.
So that brings us to the end of our session today, and I'll turn it back over to Laura.
Thanks, Todd. A couple of questions did come through. One was, how are you able to do outreach campaigns to people in specific disease states under HIPAA guidelines?
Well, first and foremost, this follows all of your traditional HIPAA guidelines. So at the point of patient registration, you should be working with those patients to understand how you can contact them and what the terms of use are going to be. So we are big proponents of the double opt-in methodology to make sure that they know what campaigns they're going to be registered in or not registered in. And so this would not be any different than many of our traditional marketing programs where we're reaching out to those patients. In addition, I would tell you that the analytics provides you with the opportunity to also segment the rest of your community, those patients who have never been to you, which you can also do marketing against.
Great, thank you. We had one more. The 3 sessions were great. How do I see what information is available in my community?
Well, the quickest way, obviously, is to contact us at info@YourCareUniverse. We can set up a demo with you for your specific community and show you the types of information that we have available already.
Thank you, Todd. It seems like we don't have any more questions. We thank you for your time today, and we'll email you the link to this session as well as the first 2 in the next few days.